So thanks for having me. It's an honor. It's always fun because I feel like that's part of why I'm here is to educate and also to offer new information and data, especially in regards to medicine. So try to stay on the cutting edge. So today I'm going to try my best to maybe give you some insight, whether you're on the journey of prevention or whether you're in the throes of a diagnosis or whether you are trying to just improve quality of life for a family member, just to give you some more, tidbits and hopes and how we have tied genomics into medicine and make it personalized. So here we go. Is it forward? So I know you all have been here probably most of the day. You've had a lot of education. Some of you are educators yourself. I don't want to beat this to death, but sometimes it gets confusing. So I'm just going to briefly kind of clear up the diagnosis and how I understand them. And then I'm going to talk to you today about functional medicine and genomics. So genomics is a form of DNA. We use it in functional medicine to make our diagnosis and our treatment plans really personalized. So everybody is individualized. We're going to talk a little bit about some case studies to show you some examples of how we use this and how we incorporate it into our practice. So this just sort of lumps it all together. You probably know this better than I do, but I get confused. So dementia is sort of the overall umbrella, and then you've got different types of dementia, and that includes even mild cognitive impairment. Those are the earlier stages. So that just helps me I'm a visual. This hopefully will help other people. Functional medicine, also using a visual reference, we like to use a tree. So as a primary care provider, I often will send a patient out to, say, neurology because they need a diagnosis for their neurological challenge, or I might have a patient that has GI challenges. I'll send them to a gastroenterologist to get a diagnosis and a workup. And then they tend to come back to me with a lot of ologists. Well, that's at the top of the tree. We've got a lot of little leaves and branches. But my question as a primary care provider that does functional medicine is, what's the root cause? How are they all related? And what's causing this to keep it going? What's making it going? What started in the first place? So I try to sort of bring it all together, individualize that to that person and look for root cause. We use a systems-based, evidence-based approach. So it's not just willy-nilly. It's really blended in my world of naturopathic, natural medicine, and allopathic medicine nicely for me. And so we tend to do that, and we optimize function based on pathophysiology and biochemistry and genetics. So that's what we're going to talk about today. So I'm going to try not to make it boring, make it kind of fun, I hope, but also informative. When we look at cognitive impairment or cognitive decline, so that's that whole umbrella we were just talking about, there's a lot of things that contribute to that. It's not just, oh, I got ApoE4. That is a really common one that we test that we can say if you have it and you have two variants of it, you're going to have a higher risk of developing Alzheimer's disease or a cognitive impairment of some kind. But it's not the only thing. There's a lot of contributing factors. And as they do more and more research, they're finding that, inability to clear out those plaques, that's one of them. Mitochondrial function, that's another. Glucose metabolism, blood sugar is a big deal. Hormone-related issues can be a huge precursor and a risk factor, modifiable risk factor. So if we know what the patient's challenged with, then I can help them change that trajectory. I can help them be more preventive. I can also slow it down and optimize their ultimate outcome. So this is just some validation, so I don't sound like up here preaching Pollyanna information. There's a lot of literature that says, hey, yoo-hoo, there's a lot of contributing factors for this cognitive impairment situation that we have. It could be bacterial. It could be micronutrients, vitamins, mineral deficiencies, or excesses. It could be oxidative stress. It could be toxins in your environment. So all of those things. I can have a patient or three people present with the same screening tool, MOCA study, say of 16, so dementia, in a moderate range, pretty significant. And they can all look the same in their presentation, but their underlying root cause can be completely different. Yours might be hormones. Yours might be toxicity exposure. Yours might be a combination thereof. Someone else's might be a vascular issue. So if I can figure that out for that patient, I can help them at least take that part out of the wheel, as I say. So there's a big wheel of things going on. The center spoke is where you get your stability. If I have three things that I can identify and optimize, then obviously the wheel will turn much smoother, right? So that's what we're going to do today. talk about cases that give you examples of this. So I just wanted to report some statistics. Oh, I didn't bring it, my exact. So every person that has a memory loss diagnosis have at least 5 to 8 modifiable factors, risk factors that they can change or modify to decrease their risk or decrease the severity of their outcome. So that's pretty significant, actually. Genomics, I keep throwing out that word. What is genomics? Genomics are small tweaks in the gene or the DNA that we have that makes it change its way it interacts with the environment. So just because you have an ApoE44 combination does not necessarily mean that you're going to develop a cognitive impairment diagnosis. It does raise your risk if your environment or your stressors turn that switch on, right? So it doesn't mean it's end all be all, but it does say, hey, your risk is a little higher, especially if you're exposed to X, Y, and Z. So that's the idea of identifying early, or at least identifying them and modifying what we're doing with them. These are the big three: ApoE4, TOM40, and ApoC1. TOM40 actually is a higher risk for developing late onset Alzheimer's, meaning after 65, than actually ApoE4. But we hear a lot of buzz about ApoE4. The ApoC1 is kind of like the light switch for all of it. So if you have a combination of all three of those, it's over 60% increased chance of developing Alzheimer's disease, actually. So the genomic test is typically done by a saliva test. So it's non-invasive. It's really easy to do. It used to be really, really expensive, tens and thousands of dollars when they first started doing, genomic testing. Now it's not all that cheap, but it's about $2,000 for a comprehensive one. The IL-6 is an inflammatory marker that is important in this process. And the MTHFR, a lot of people have heard of, that has to do with the methylation of folate and B12. So we'll talk about this, and I brought those up because those are the big hitters. Let's look at a couple of cases, because otherwise I get boring. Lenny is an international businessman. He is 47 years old, and he came in and he said, you know what? I'm having trouble remembering names. I know it's not really a huge issue, but my mom and dad both have some Alzheimer's type presentation, and I don't want to get it, and I'm getting kind of scared. Well, incidentally, his MoCA score was actually 24. That put him in a mild cognitive impairment range. And so he really, truly was having trouble. He noticed it was worse when he was traveling and not sleeping. So for a long time, he kept saying, oh, I'm just really tired. It's no big deal. He started researching on his own. He did some Dale Bredesen information. He started a ketogenic diet. He was taking about 12 plus supplements a day, and it wasn't getting better. So that's when he said, there's got to be something else, maybe something I'm missing. It was really interesting because he had a very obvious answer to his question: why am I presenting the way I'm presenting, and why am I not getting better with the stuff I'm doing? He had 2 interesting little SNPs, and SNPs is a short word for single nucleotide polymorphism, those tweaks in the DNA I was talking about earlier. And his were relative to circulation to the brain. So for him, increasing circulation was going to be really, really important. And he was not targeting that. And in the red down there, you see at the bottom, he had an F2 and F5. Doesn't mean much to anybody, but it really is pretty rare. Less than 3% of the population has double variant F2. Less than 5% of the population has the other one. So it was really interesting for him. It was like, bing, this might be a big deal. So this is just some information relative to actually cognitive decline. So you can see that it actually has been researched and studied relative to Alzheimer's. What did we do? So I tested his fibrinogen levels, which is something you would do if you saw that combination. Easy, the blood test, super simple. Quest, LabCorp, they have that. If it was less than 300 to be normal, his was about 500 plus. If it's greater than 700, then he needs a medication for anticoagulation because he's clotting things. So when you get a lot of microvessels that clot up in the brain, our brain starts to shrink. And a lot of times you'll get an MRI or an image of the brain and someone will say, oh, it's just normal for aging to have a shrinking brain. No, it's not. You need blood flow to the brain. It's not normal. Okay, so his was actually small on a CT scan, and this is why. So we used something natural to help thin his blood instead of using a medicine because he wasn't in the high-risk category. These are the 2 things that we used, pycnogenol and lumbar kinase. Here's the information supporting that, evidence-based medicine. So we didn't have to jump right into medications for him. This is the other one that we used. It's from white pine bark. It's really interesting. Lenny had also some difficulties with his hormone levels. He was 47 years old and he was having trouble converting testosterone to estrogen. And as you all know, if you don't know, you're going to know now, we have a ton of the testosterone and estrogen receptors in the brain. After menopause, for women, when their estrogen starts to fall, they'll say, man, I have brain fog. I can't remember anything. It's because you're starving for that estrogen to help things work in the brain. Same for men. And his testosterone is actually really low at 9. And for men, it needs to be about 10 to 30 or 10 to 50. It depends on who you talk to. And so what we did is we tried to help him by optimizing his testosterone level so that it would convert into estrogen and he have more food for the brain, so to speak. So we did a few other things for him because we did find that he has some other little things like his blood sugar regulation was important. He does not need to be on a ketogenic diet based on his genetics. It was actually a terrible thing for him. It was hurting his mitochondria more than it was helping. So we took him off of that. We helped him with his thyroid and we found out that he has trouble transporting B12. So we optimized B12. When he came back to us, his MOCA score was a 29. So drastic improvement. He was happy. He wasn't on those other 12 supplements, so that was really nice. And he was using mostly lifestyle modification diet specifically. So another example is a professor. We named him Paul. He's a 75 or 71-year-old retired physics professor, and memory for him is his identifiable personality trait. It was really important for him. And so as things started to wane, it really hurt him. He got depressed. His wife brought him in. Actually, it wasn't him. And he had a slum score of 19, which is actually a diagnosis of dementia. That made it worse because now he's really sad about his diagnosis. And so he sort of was spiraling. What we did is he didn't have a family history of any kind of cognitive impairment. So that's also a red flag to me. That means that maybe something else is going on and to make him present like or get the diagnosis of dementia. So it was going to be interesting to see what he came up with in his genomic panel. He had a double variant of this TOM40 that I was telling you about earlier. And you all don't know that because we don't talk about this one very much, but it can be almost up to 4 times the risk of dementia if you have 2 variants of this, and he did. So he was presenting in that big umbrella that I showed you earlier with a form of dementia, and he really was at a risk, even though I didn't have the family history. So perk this up a little bit more. But his big challenge was mitochondrial issues. So he was having trouble with healthy mitochondria. Those are your powerhouses of your cells. They're what gives you energy. They help clean up things. They help take out the trash. They're like the best friend of the body. So we wanted to make sure his cells didn't look like this and they look like that. We wanted to plump them up and get them healthy. And how do we do that? We can do it by several nutrients. NAD plus is a really big fancy thing out there. They're doing IV, oral, etc. It's in the anti-aging world, but it's actually a supplement. It's a nucleotide based from niacin, and it's used to help those mitochondria do what they're supposed to be doing. And so we did intervene and help him with NAD from a supplement standpoint, but we also put him on the keto type diet, very strict keto diet, because that can actually raise NAD plus. So for him, it was a good thing. For Lenny, the other guy, the ketogenic diet was actually not a great thing. So this is that individualized part. And if you look at his other little snips that we identified, some interesting thing was, is this a pointer? Yeah. This choline here has to do with the coverings of nerves. It also helps increase acetylcholine. And if you all know anything about the medications we use for cognitive impairment and challenges, it would be Aricept and Namenda, for example, they're related to that acetylcholine. So what we were trying to do is help him naturally make that himself. So we gave him some choline in his diet. We also found that he had trouble with calcifying his arteries here. So we gave him some vitamin K2 that reduces the calcification in the arteries. We made sure that we optimized his B6 because he had trouble there. And we lowered some inflammation with exercise and sauna use. I'm going to skip that. That's boring. Okay. So this is a little bit of evidence about that choline I was talking about. It also helps repair the coverings on your nerves. So if you look at the wire that we would use for a light switch, it has that plastic covering on it. That's kind of like our nerves that run back and forth and give messages from the brain to the body. They also have a plastic covering, and that's mostly made up of choline. So we were trying to help him have better and faster communication in the brain by adding the choline in the diet. Eggs are a really great source of choline. This is just some information that tells you how important it is related to cognitive impairment. He also should have been on a statin because his cholesterol was really high and his inflammation in his arteries were also very high, but he said, I couldn't take the statin. Oh, and he also had evidence of an old stroke on imaging, brain imaging. He said, I couldn't take the statin that my cardiovascular doctor prescribed because I kept getting muscle aches. Well, he had this interesting little variant in his genome that caused him to not actually break down the CoQ10. So if you know anything about statin medication, they're not bad medications, but they do block the liver's production of CoQ10, coenzyme Q10. And so if you're already low or you're not able to metabolize it and we give you a medicine that drops it down, it's responsible for helping us keep our muscles from breaking down. So if I give you a statin medication, you're already low on CoQ10, it drops it even lower, your muscles are going to hurt. So if you give them CoQ10 or the bioavailable form called ubiquinol, which is what we use for him, I always usually tell my patients, if you've had that experience, take it a couple weeks before you start your statin and keep your statin at a lower dose. So what we did is we put him on it 4 times a week at a lower dose with the ubiquinol and no muscle pain. So he did really well. He wasn't on a whole lot. We had him on some resolvins, which is a form of omega-3 to help with inflammation modulation. We put him on the choline, the K2, and so forth. And the diet was really specific. He worked with our dietitian. His slums increased from 19 to 27. So he actually had a drastic improvement and he was very excited. Now he's the one, he encouraged his wife to do it after she brought him in the first time. So he made her do the test. So anyway, it was fun, really cool. This is the last one that I'm going to talk about, and then I'll kind of open up for questions because I think it'd be more interactive if you guys got involved. This young lady, she was in her 50s and she decided to get healthy. She went vegan, fine. She was very anti-inflammatory based eating. She noticed some problems with word find. This is also around the time that she was entering menopause as well. So I just gave you a hint earlier about the hormone connection, especially for women. She exercised well. She was resting well. She was actually had a very, very healthy lifestyle habit. And so she presented really more to be preventive. Mom and dad both have some issues, grandparents also as well. So she was just worried, what's coming down the pipe for me? What's it look like? So what we did is we did a little investigation for her with her genomics, and we found a couple of interesting things. This one here, this BDNF SNP, this mutation that she had, has to do with fertilizer for the brain. That's what I call it. It's not really, but it basically gives it food and fuel. So we have trouble with food and fuel for the brain. Can we help that? Yes. Guess what helps it? Where's the lady that was speaking earlier? Exercise. Exercise helps it. So if you go to the Village Park or the Magnolia Place, you're going to exercise and you're going to increase your BDNF, which is awesome. Also, she had a high tendency for inflammatory responses to infection. So if she had COVID, she noticed a huge cognitive impairment issue for about 6 weeks afterwards. Couldn't remember, felt like her brain was heavy, sluggish, and all that business. She had trouble transporting B12 to the brain. So this is interesting. I have a lot of physicians that will say, why are you giving this patient B12? Their B12 in their blood is really high. It may be high in the blood when you draw it, but if they're not able to transport it across the blood-brain barrier, they're starved for B12, and it's very, very important for cognition. It also is important for balance. So if you have patients that are off balance and their B12 is low, if they have a mutation, or if you even suspect it, if you push it a little higher and they get better, yay. I actually got in trouble when I was first in practice in Grove, Oklahoma. Anybody know where Grove is? On the lake? Yeah, it's a big retirement community. And so I was working at a couple of the nursing homes. And I just, being excited and zealous, going through their charts and looking at their labs. And I noticed a lot of them had some indicators that suggested low B12. So I started replacing B12, which was awesome, actually. But I got called in. So with the CMO of the hospital, and I had to go meet with the director of one nursing home. And he said, Dr. Herbst, I noticed that you've been checking a lot of B12 levels and you're giving a lot of B12 injections. I need you to stop doing that. When I said, oh, why? The trouble? Are you having trouble with it? He said, no, we had to increase activity staff. So I was really actually quite offended. I wanted to cry when I left. I looked over at my boss and I said, did he really just tell me to stop getting people well? And he said, no, that's not really what he said. So anyway, I did. I actually became known as the vitamin D and B12 doctor for a long time. Take it. Okay. Decrease the B12 through the blood. We talked about that. The MTHFR and IL-6 is an interesting one. This can increase your risk for Alzheimer's disease, just having those two. Inflammatory marker and the methylation issue for folate increases 2 times, 3 times for vascular dementia. So those are 2 very simple things that we can target. You can actually test MTHFR at your local commercial labs by blood now. She also had trouble converting T3 to T4 in the brain. This is also a very important point. If there are providers out here, I get constant questions about, why are you treating the T3 on thyroid? I give them T4, levothyroxine or Synthroid. That's fantastic. If the person can convert it, fine. If they cannot convert it, then it's useless to them. If you need T3, which is the active form of thyroid in the brain, to think and to have energy, you have got to make sure you're capitalizing or optimizing that level for that patient, or they feel like they have low thyroid. They can't think, they're depressed, they have no energy, their health falls out, they're constipated, their skin is cold, their hands are cold, their body is cold, they feel crummy. And so the point is, there's a lot more to the thyroid than just checking T4 or TSH, especially in this special population. And she was one of those patients. So we did some really nifty things for her BDNF. That's the brain fertilizer. Exercise is actually the biggest winner chicken dinner. And I know a lot of people roll their eyes when they say exercise is good for a lot of things, but it really truly is. This is, I wanted to show you the ending here. So there's some really simple things. I talked a little bit about this methyl tetrahydrofolate reductase. That's why we call it MTHFR. Some people choose to call it something not so nice. And IL-6. So the two combined, actually not too hard to treat. You can give them a nice bioavailable B complex, and you can add in some green tea extract that gives them a little bit of energy, perks them up, and it's not harmful. Green tea extract, the EGCG, also is fantastic for osteoporosis. And sulforaphanes comes from 3-day-old broccoli sprouts, also really powerful for removing plaques in the brain for Alzheimer's patients. So not such a bad little combination there. We worked with our dietitian as well. Quercetin is high in apples, for instance. You can, obviously, people know what curcumin or turmeric is. I will say, you have to eat a lot of turmeric. You'd probably be yellow. Your fingers would be pretty yellow if you're going to eat that much. So you might get a pill. Be an awful lot of turmeric you have to consume to have the benefit of the anti-inflammatory component. So for her, this is that B12 conversation I was talking about. She not only had trouble transporting out of the GI tract, but also transported across blood-brain barrier. So that's a TCN2 SNP. And it has actually about 30% of the population or more have two carriers. So it's actually pretty common. It's not going to hurt your loved one to try a little methyl B12 injection and see if they get better. You're not going to overdose them on B12. So there's that. So this was her overall pick. Oh, this is my rant about the thyroid. So you guys heard that enough there. So that was how she is. She's actually doing better, but the fun fact for her is actually her word finding got better, but her migraines are actually improving. And that really probably had to do with her thyroid getting across the blood-brain barrier for her and the B12. There's a lot of information about genomics and individual genomics, SNPs like we just talked about, like your Tom40s, your ApoE4, but there's also some newer literature about these modifiable factors. If you are a science nerd and you want to read, or if you've got a doctor that's challenging you and says, once you have the disease, you always have the disease, there's nothing you can do about it, man, I'd be empowered and I'd stand up and say, yeah, there is something you can do about it. You just aren't right up on the literature. So research, be proactive, be empowered, and as we say at SALT, live life healthy. I think I'm supposed to leave some time for questions. So if you're not asleep from your lunch, I'm open for questions. So advanced makes it challenging because it's really hard for them to be compliant, right? It becomes a team effort. I've had MOCA scores when I was at Cleveland Clinic at 5 or lower. So higher, 25 or higher. Really significant, but it took a team and it was huge. The vascular is actually easier because you just have to increase peripheral blood flow, and they do have improvement. So it really only takes maybe 1 or 2 supplements and maybe some powder that has some arginine and some beetroot in it that helps increase blood flow to the brain. And you can have some pretty significant change, but it does take a pretty big team effort because they're usually not as, in my experience. Good. So here's the question. It depends on what's causing it. For instance, we had a gentleman that had a really severe diagnosis, bad scores all around. And his ended up being pesticide exposure in the last 10 years. So once we detoxed pesticide IV, he didn't have to do anything. We just pulled it with a chelator. He actually improved glutathione and IV chelation, improved his cognitive scores. So it depends on what the ultimate root cause is. But if you're talking about bradycardia or vascular type dementia, usually there's a blood flow, nitric oxide component. I don't know that you're going to reverse it per se, but improving cognitive abilities and quality of life is always a possibility. Absolutely. Depends on how willing they are to cooperate and how willing you are to work. So THC sativa is a little bit more awake. There are some actually good studies with the CBD component, the endocannabinoid component. And interestingly enough, the DNA panel that we do, genomic panel, there's an entire endocannabinoid section. So we can see if they have receptors that need support. And those patients do respond well to supplementing with CBD THC combos. But as far as individually, I'm not really sure. Did it help? She's asking if the THC gummy would help with the anger and the aggression, correct? In the morning? Have you tried it? Not yet. Oh, yeah. Yeah. Well, there you go. Yeah. Good. Yeah, so it can actually be very anti-inflammatory. There's a lot of literature that shows that it's not legal in the state, or actually it is now legal in the state. I shouldn't say that, medically legal. We don't have a lot of research, as much research, because it was squashed for a while, right? So now it's coming out to say, hey, actually there's endocannabinoid receptors all over the body. We could all use some of this. So positive. If they respond clinically, I would say it's great. Not yet. You're welcome. Not yet. Not yet. Anywhere in the middle or mild to moderate is a powerful place to be, because you have opportunities to fix several of the things that are adding to the fire. So you have the diagnosis in the middle. That's your fire. If I'm pouring gasoline in the form of nutrient deficiencies, if I'm pouring gasoline in the form of hormone imbalances, if I'm pouring the gasoline of toxin exposure, and I can remove and identify any of those, the fire goes down. The disease doesn't go away per se, but the fire goes down, right? So improvement, always a possibility. It depends on how many things the person can identify. It depends on how willing they are to correct the situation. Same goes for everybody else, but there's always that potential. It's not a pie in the sky. It's not a Pollyanna promise. It's just identifying and seeing what we have. If there's something that makes sense, get rid of it, fix it, optimize it, and see what happens. And that's really where it comes. They're showing such really good promise in this world of individualized, personalized treatment. It's not easy. It's not cheap, but nor is long-term care. And that's the hard part. At first, they were like, nobody's going to pay it. They don't want to do that. It's too hard. Lifestyle change is hard. They'd rather eat Twinkies and whatever. Fair enough. If that's your choice, then we support that. If it's not your choice, or if you say, I don't really like how this is going, then what am I going to do differently? Used to, when I was trained, it was like, oh, you got the disease. Sorry, I'll see you in the nursing home. Love you while you're fun. That's kind of crappy. So my point is, if no matter where you are on that spectrum, I always think there's a chance. And I'll be honest with people. I'll say, we may do the test and not a whole lot shows up, or you may have all four of those big hitters and you're pretty progressed. Here's what you can do to optimize what you got. But I don't know that we're going to change it per se. So I think it just depends on the person, really. Love you, what? 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 Love it. Sauna, infrared sauna is one thing. Red light therapy is another. I'm a little bit more well-versed on infrared sauna. From a vascular standpoint, we know that it is a huge reduction of inflammatory markers, especially CRP. So 20 minutes on average. Most of the studies were done in Europe. 20 minutes on average, 3 or 4 times a week, reduced cardiovascular events over 60%. That's huge. That's better than any medicine that we can give somebody. Red light therapy, from what I understand, can penetrate into the tissue a certain depth based on the wavelength that you're using, and can modulate mitochondrial activity, those little funny cells that we were talking about, powerhouses. And it can also help modulate the response of the inflammation or the inflammatory pathways. So I don't know how far it's penetrating per se, because I'm not that savvy on this information, but I do think it's a promising tool we have out there. It's not going to harm anybody. So I think it's a nice little tool. Infrared sauna, powerful. It helps increase blood flow, decreases inflammation. The 20 minutes, 25 minutes in the sauna is about average as far as the outcomes from lowering inflammation and getting positive benefit to a mild jog. So I don't know about you, don't like to run, rather sit in the sauna. So that's a good option for me. So there's that. Does that answer your question somewhat? Mhm. Yeah, absolutely. So exercise is kind of an irritating word to me. In the past, I loved exercise, and then I went through a life challenge where exercise was getting dressed was hard. So exercise was not even on the table. And so when someone say you get better if you exercise, I want to punch them in the nose. So exercise means a lot of different things. It could be sitting in the sauna, raising your heart rate, getting your body to vasodilate and sweat, and that is your exercise for the day. Fantastic. It could be a breathing or breathwork exercise every day. It could be a walk around the block. It could be an actual class. It'd be great. It could be chair exercise. So I think exercise of some sort, whatever fits that person, should be kudos. We should give them pats on the back and encourage them every single day to do something. That would be one, movement, activity of some sort. Number two, reduction in sugar. As we go through the disease process, all they want is sugar and carbs. Why? Because the brain is starving. They will hoard candy, as you'll probably know. They will only want to eat Twinkies or donuts. So if we can start early and we keep our glucose level and balanced, we will have less of a progression of the disease. The neurologists now have named dementia type 3 diabetes because as our glucose levels are greater than 5.7 on A1C average, you're losing 1% brain volume every year. So that pre-diabetic range is crap. Get out of it. Get down lower. If your doctor tells you that it's okay, you're not diabetic yet, he doesn't love you. That's all I'm saying. Okay. So glucose, blood sugar, keeping sugar out of the diet, processed foods out of the diet, movement and exercise. If you have access to a sauna, I would say use the sauna. Socialization, brain games. Those are my two other favorites. So brain games, and also not just brain games. People go, oh, I love doing the word puzzle. I'm like, then don't do the word puzzle, do the math puzzle. You need to do the things that you don't like to do because you're not challenging the brain to make new nerve pathways, if you are. If you can't dance like me and you have two left feet, you should be dancing. If you love math, then you should be doing word find. If you love math, you probably should learn how to play the piano. You need to challenge yourself in areas that you're not used to challenging. Another simple tool, brush your teeth. If you have one tooth, brush your tooth. Brush your teeth with the opposite hand. Start early. I did it when I first started. I used to jab. I had cuts in my gums, so be careful. It's dangerous. But try things like that because it challenges you. When you get dressed, you know how we always if you wear underwear, you put your underwear on with one foot first, try the other foot. Start with the other foot. Oh, that's hard. That sounds easy, doesn't it? Not. That's really important. And my last and not least would be balance. Core exercises for balance. Fall risk. People that fall and have a fracture, they're more prone to progression of disease. So an illness. So I'd say core exercises for balance. Every day when you're doing your one opposite toothbrush, you're going to stand on your leg or you do the other one. So little things like that can help. Those are my big tips that I can think of. What's the doc? I do. At least they're reading the anti-aging literature. That's awesome. She said, what if your doctor gives you metformin and pats you on the back? First of all, metformin, immediate release, the cheap one, can give you diarrhea. So you're going to give it right back to him and say, thanks very much. I'm just kidding. Actually, metformin, not a bad thing, especially if you're running in the higher glucose. I put glucose monitors on a lot of our members, our patients, because I'm really strict and I want that control tight. Metformin has some really good literature. The downside of metformin, it lowers B12. So if you're already challenged with B12 and you're taking metformin 3 or 4 weeks, 3 months in, and you say, I don't know why my neuropathy is getting bad and I can't think, it might be because your B12 is getting lower. So medicines aren't bad. You just have to know what they're doing and how to complement them. So yeah, kudos to him for thinking ahead and being preventive, lowering your blood sugar. Bad for him for giving you the diarrhea one. Tell him you want the extended release. That one doesn't have Miralax in it. What else? Anything else? Yeah. I do. So Parkinson's falls in the same category as your neurodegenerative in my mind. So it's the same thing, root cause. The big eye opener I had many, many years ago when it was right before I went to Cleveland Clinic. There was a doctor in Naples that did a big study on glutathione. He wrote brain. I can't remember his brain. I can't remember his name. Anyway, he gave glutathione to a patient and videoed him before and after with Parkinson's and shuffling walk, couldn't talk, and then give IV glutathione. Glutathione is an antioxidant made in the liver. It's a really powerful antioxidant. And he literally was walking and talking post the IV. And it was a big eye opener. That patient's reason was his body didn't clear heavy metals very well, and his heavy metal levels were really high. And when you give glutathione, it helped clear it. It also helps repair this mitochondria. So it was an eye opener. It kind of falls in that same neurodegenerative category for me. Root cause is always the question. Yeah. Well, like a layman's book that I recommend for. Yeah, probably the brain grain, the, what is his name? My book, okay, no, just kidding. Peter Osborne's a good one. Okay, there you go. Peter Osborne's a good one. My book is more for empowering patients to talk to their doctors about this type of stuff. How do you go into the doctor and say, hey, I have a family history of Alzheimer's and I want to prevent it? And they go, here's some metformin. See you later. Exercise. There's more to the picture. So I have sections on thyroid. I have sections on detoxification. I have sections on genomics so that you can ask questions and be empowered. I also give the literature so that when they roll their eyes or their hair lights on fire, you can say, oh, here's some information that actually validates that question. That way they don't shut you down. No, that was mine. They said, what about yours? And that was my book. It was called Functional Medicine and Primary Care, How Can We Get Better Together was the name of it. It's on Amazon. I wrote it to help educate patients because I was a patient and I wasn't getting anywhere in the healthcare system and I kept getting shut down and they thought I was crazy. And I just knew there was more to it. So that's why I wrote it. So that goes back to that same gentleman in the thing. I was probably too boring. You fell asleep. It's okay. Just kidding. Just kidding. Yeah. So she says, I'm taking statins and I get these sore muscles and sore joints. So you may be one of those people that when we give you a statin, it's not the statin that's the problem. It's the body that doesn't make enough of that CoQ10. And CoQ10 prevents your body from muscle breakdown. And so if I give you a statin that blocks CoQ10 production and you're already low, I'm making it worse, right? So it might be helping your cholesterol, but now it's hurting your muscles. And your heart's a muscle, by the way. So it's not really helping the overall picture in my mind. So taking ubiquinol or the bioavailable form of CoQ10 would be what I would do with you. I would have you stop the statin for about 3 or 4 weeks, load you up on the ubiquinol, and then restart at a low dose. And usually people do really, really well. Then you can have the best of both worlds, right? Or when do I come back to that one? Just kidding. Yes, you have to be a very wise, informed consumer. There are a lot of good products on the market. I use a few brands only because I've researched them and I stick to them. I'm not sold by any. I don't have any marketing connection to any of them. When I was at Cleveland Clinic and we did research, we had to do a lot of investigation into companies and products we were using for IRB purposes for research. So that's how I learned the ones that I use. What I would say is being a wise consumer is asking for quality control, making sure there's not a whole bunch of other ingredients in your supplement that you're buying, and make sure that they're in the bioavailable form. So for instance, if you go pick up a one a day, there's a lot of talcum powder and dye. You're not an Easter egg. Don't need the dye. So let's just leave that on the shelf. Okay. They're going to put fillers in them. And then there's not a whole lot of regulations. So you want good quality without a lot of other ingredients, no dyes, and you want bioavailable forms. If you buy a product and it tells you in parentheses what your B6 is, for instance, P5P is the most bioavailable form of B6. If it says it, they are so proud of their product. Yay for them. Because they're saying, hey, we used the really good stuff. If you compare it to one that doesn't have that and it just says B6, you got to wonder what they're putting in. Okay, so you're looking for bioavailable. bioavailable, so more available, the most easiest to absorb is what we're looking for. A good trick that I used to actually teach a class on how do you know what you're getting a good supplement. If you look on the back and you look down for vitamin E, if it says D, L, tocopherol. L is for losers. Everybody do this. Losers. L is for losers. That means it is synthetic. Put it back on the shelf. We don't want it. That's an easy way. And if they're putting that in there, they're cheating on the other stuff. So just put it back. So that's some of the little tips I would say. Pure L is for losers. No, just kidding. Just kidding. Just teasing. Yes. So DL, tocopherol, is a really common form of vitamin E that's really inexpensive and it's synthetic. You avoid it. The other tip about vitamin E, if it says vitamin E on the back of a vitamin and it doesn't have mixed tocopherols, you actually don't want it. Remember the big study not too long ago where they said vitamin E causes heart problems? Sometimes they said it was good, then they said it was bad, and they're like, it's bad. That form of vitamin E is very oxidized easily, so it actually does cause problems. So DL is synthetic. DL tocopherol is a good example. Pure encapsulation is one I know we use for research purposes. They're very clean. You usually have to get them through a provider. Another warning, if you buy these provider-only ones on Amazon, it means that the provider had a shipment that got too hot or maybe too cold and we couldn't sell it. And some people are nasty and they sell it to people on Amazon and then you buy it off Amazon. So warning, if it's a provider-only, and it'll say it on the bottles, provider-onlys, if you're buying that on Amazon, you better watch out what you're buying because it's probably hard and crunchy and gross and nasty. But Pure Encapsulation Designs for Health is a good one, and they do sell on Amazon. Seeking Health also sells on Amazon. Seeking Health is a good one that has choline. Seeking Health. Designs for Health has a good form of choline and a few other things that we mentioned today. Pure Encapsulation has a wonderful B complex. It's very inexpensive. And they have a 1-a-day multivitamin that's really hard to find bioavailable 1-a-days because nobody likes to take a bunch of pills. Awesome. So just reference to the lecture, D in general is great, D3 especially. A lot of times doctors will prescribe a 50,000 once a week. Also a fun fact for you guys, the 50,000 once a week still circulating in the pharmacies are D2, heads up. So when you go and you pick up your script for your once a week vitamin D3, if it doesn't say cholecalciferol, starts with the CH, you don't want it. Give it back. Tell them you want the cholecalciferol. They'll give you ergocalciferol, which is D2. Not the same thing. Not at all the same thing. It's not helping your loved one at all. So you want cholecalciferol, chole, C-H-O-L-E. That's all you have to remember. It's vitamin D3. It's the one per week, 50,000 that doctors will write as a prescription. So if your loved one is on D3, check and see what they're taking because it's not helping them if it's D2. And they're D3, so it's wonderful. That's what you want. Yes, they do. Yep, exactly. My tip there was with patients that have cardiovascular dementia or vascular type dementia, they actually need the K2. Look at me, sign language. They actually need the K2. And he said he has a product that has that. So that's really important. Yeah. You're on a Fayetteville? What? Wow, right. That's so cool. I feel like you're a celebrity. They are. That's really good. They're a very clean company. I know, right? Yes, you. Sure. You're green. Or not provider. What? So typically, Pure Encapsulation is supposed to be provider sold only. So you have to have a license, either a pharmaceutical doctorate license or a physician license to sell that. If someone has purchased a bunch and they sat outside and got too hot, we can't sell those. I can't sell them. So I have to chalk it up to a loss, right? Well, some people aren't so honest and they will sell to a higher bidder. I don't know how they do it, but somehow it keeps getting up on Amazon. And so that's what I say. Just be warned, if it's a provider-only supplement, those are really to be careful online purchase. The panel that we do, called the executive panel, looks at everything from nutrients, hormones, detox, cardiovascular, stroke, diabetes, obesity. and cognitive impairment. So it actually is a huge preventive bit of information. If a person comes to us, what I do is I have their history and I look at their top 3 concerns and I do the interpretation and plan based on their top 3 concerns. So if it's not cognitive impairment and I happen to see a few red flags, I'll tell you, but I'm going to give it focused on what you're more prone to having, in your long-term scope so that you can be preventive. It's actually a really powerful tool, to be honest. And the earlier, the better. Yeah. Oh, absolutely. I think out of all the 20 years of my practice, the one test, bang for buck, is your genomic test because it will always be what you have. They are continually updating it. The company that I use does not have a name associated with that. The whole 23andMe debacle, but bad. This company gives you a barcode, which is good and bad. If you lose the barcode, I can't help you get your information because I don't know who you are based on that anymore. But the good part is there will never be an association with you. And in our practice, I don't ever put a diagnosis based on that. So there's no insurance. Later in life, need life insurance. Oh, Dr. Herbst said you have I'm at risk. Yeah, we don't want that. So the point is, it's a really powerful tool if used correctly. The earlier you test, the better, because I can say, hey, guess what? If you drink more than 2 cups of coffee, for instance, there's a SNP called COMT. If you drink more than 2 cups of coffee per day and you have this double variant, your increased risk for a heart attack, stress-induced heart attack, is greater than 55%. Holy crap. If I knew that, then I'd probably reduce my 2 cups of coffee to 1, something like that. So there's just really neat little nuggets in there that are powerful. Yes and no. So we've had people that have tried that and they end up asking for the interpretation. It's a huge packet, like 142 pages of information. And it gets confusing because you may read a section that says you need B12 in this form, and then you may read 2 other things that say you need B12 in this form, and you're like, you may end up taking 800 different things, and then that's really confusing. So that's not really what we want. It's probably better to have someone whittle it down for you. But yeah, I mean, anybody could probably read through it. So we actually offer this package to people that are non-members because I think it's that important. So you come in, you do the cheek swabby thing, you get your information I'm not really good at this part. Salt Health in Bentonville, Arkansas, where I live most of the day. So you come then, you get your cheek swab, the dietitian swab tells you all about it. We get a little bit of history, then you'll come back and you have your plan. And I and my team have spent about 2.5 hours making a plan. So we go through all the information, your history, put it together, and here's your labs that your doctor should follow annually. Here's your lifestyle things like diet, exercise, Actually, it will tell you if you do well with cold exposure. It tells you if you do better with moderate exercise or less exercise or more exercise. It can tell you whether or not you respond to that cryotherapy stuff that people use to shrink their fat cells. You pay a lot of money for that stuff. And if you're the small population that it works, great. If you're not, well, you wasted your money. So anyway, it tells you a lot of really cool things. And then we give that to you. And then I will say one of my missions is to offer this type of medicine to the mass majority. I was a very poor patient when I was sick. I know it sounds expensive, but my colleagues that do functional medicine are charging tens of thousands of dollars to take care of patients. We've tried to keep it minimal. I know it seems elitist. I hate that part of it, but it costs to have a team. It costs to have a dietitian. It costs to have a health coach. It costs for my education. So I try really, really, really hard. We give scholarships at our office. And I have not raised the price on the genomics as I've been advised to. Average national price, if you look at the full 142-page panel, is over $5,000. So we're trying to keep it low, if that helps any. Yes, sir. So I don't need my brain to shrink anymore. It needs to stay where it's at least, preferably grow. But yeah, 5.7 A1C, which is your average glucose over the last 3 months. The blood test that your primary care provider can check. It tells you whether or not you're diabetic or pre-diabetic or whatever. And we want to keep that less than 5.7, ideally 5.4 or less. 1% brain volume loss, so shrinkage per year. Yeah, it is. Sure is. And I will tell you, even the way I was trained, 5.7 is good. I would have pat you on the back and said, good job, thumbs up. 5'8". Okay, you're not 6 yet. You're not 6'5" yet. Diabetes diagnosis is a little bit of a variance depending on whose guidelines you're following, but 6.0 is 6.5 is typically the diagnosis for diabetes. And then we get excited and give you metformin and you have diarrhea. And then, I was kidding. But that's when we start treating. Unfortunately, you need to be starting way earlier. And it's not that. I mean, it's hard. This form of medicine is a very proactive medicine. You don't come and see me and expect to be passive. I'm not going to hand you the pill and let you walk away. I'm going to drive you crazy, actually. My team will drive you crazy. We're going to stay on top of it, make sure you're doing the things you should be doing. People actually say, why do you always have me come in every 3 months? So I can stay on top of it. We can course correct quickly. I can make sure you have accountability, et cetera, et cetera. So the idea is to change primary care. Functional medicine is out there. It's a very concierge approach. It's root cause medicine. It's awesome. The problem is you can go do this stuff. You can get a neat little detox plan. But what happens when you have diabetes diagnosis? What happens when you have high blood pressure? What happens when you have a stroke and you get discharged from the hospital and you go to your primary care and he goes, why are you taking that white pine bark crap? That's dumb. Stop it. You don't need that vitamin. That doesn't work. Stop that. Nobody needs vitamin D. Who cares? Put it over here. It's confusing. So my goal is to help primary care providers give more of that comprehensive root cause approach to patients. And that's what we do. That's what's different. Yeah, we do. That's fun. Yes, ma'am. Absolutely. Especially on those genomic panels, if they have trouble with detox, there's two sections actually on that, about 8 pages worth of detox SNPs. And if you have trouble clearing mold, or if you have trouble clearing pesticides, if you have trouble clearing heavy metals, and you tell me that you used to paint, I actually had a whole entire family. The husband and wife started a painting company. And back in the late 80s, they were doing their own scraping and painting. And then we do their genomics, couldn't figure out why they're all tired. The kids had IQ problems and behavioral issues. All of them are lead toxic like nobody's business. The parents had the genomics done. They were poor detoxifiers, both of them. I said, well, you better probably check heavy metal levels. Theirs was high. Check the kids. Theirs was high. Really interesting. So yes, we do address the toxins if appropriate. Depends. Depends on the patient and who we're talking to. If they come for just genomics, that would give me a hint like, oh, we should probably check it. But if you come to me as a patient and I get it in your history, that you've been exposed, then it's going to be on the docket for checking. So that infectious disease study was for Lyme or tick-borne illness. Yeah. That's a really interesting statement. So it is really hard. A lot of times when we get a diagnosis, we feel like every ache and bump that we have is from that, because we're hanging on to something. When we feel like everything is so out of control and our body is not behaving the way we want it to, that's the only thing we can explain. It's really hard because it's usually not that simple. It's not linear. It's not one thing. Usually it's a very big, complex presentation. Lyme disease is interesting, though. It actually causes a myriad of presentations: GI, cognitive, neurological, mood disorders. And the interesting thing about Lyme or tick-borne illness, ticks are like dirty needles. They carry viruses, they carry bacteria, they carry parasites. And so actually it could be a lot of different things that they present with. The hard part is we oftentimes fall into the trap of being identified with our disease state. And I think that's a challenge. It's a change in mental thinking. The best thing you can do is support them, share gentle education, but also acknowledge it could very well be every funny little bump and hump they have might be related, because it does present in some really weird ways. It's hard. It's a hard disease, actually. And then it doesn't get a lot of recognition. Chronic tick-borne illness is kind of poo-pooed in our typical infectious disease society. Hard. Fibromyalgia is a big catch-all. It's just like arthritis. It just basically means your muscles hurt. Well, whoopie-doo-doo. Thanks for that. So why do they hurt is the question, right? I had a doctor actually gave me that diagnosis once, and I was like, okay, now what? I already know they hurt. That's why I'm here. That's the whole point. Arthritis, same thing. Arth, joint, itis, inflammation. Okay, so what? How and why, and what can I do to get it better? That's the question, right? So big catch-all umbrella diagnoses. Same with dementia, Alzheimer's, Lewy bodies. What's causing it? Why do I have it? What started it? How can I prevent it? How can I reverse it? That's what we should be asking. Okay, I'll leave you with that. Thanks for your attention.